So in approaching pediatric ankle, this patient is 14 years old and presents with 4-year history of ankle pain and limited range of motion. So let's take a look. So the first thing I'm going to do is do a thorough assessment of all the structures so that I can be sure each and every time I look at these cases, I don't miss anything extra, don't overlook things, and just go into tunnel the case, because it's easy when you see things like this, like in this case, a middle facet coalition, to just go right into it. But let's make sure that we see all of our structures. So we're going to take a look at the medial flexors. We're noticing that there is medial retromalleolar ossification here, and there is some type of hyperintense signal change within the posterior tibial tendon. We can take the posterior tibial tendon to its insertion. It's slightly tendinopathic and thickened at the insertion, very subtle. And it is also has a slight enlargement. It's more than 1.5 times the size of the flexor digitorum. So then looking at the flexor digitorum and flexor hallucis, those are normal. I go to the master knot of Henry just to make sure that there's no tenosynovitis, and we're finished with that area. Then I want to take a look at the tarsal tunnel. I want to see the posterior tibial nerve, and I want to understand, do the muscles have any type of atrophy? I want to be able to pick up early branch nerve compressions, and I don't have any of that in this case. Then I'm going to go over to my peroneal tendons, noticing my brevis in front of my longus. I can see my superior peroneal retinacular band and also the region of the fibrous ridge, and I notice that there is no subluxation. In this region of the inframalleolar groove, this is often an area of peroneal tendon indistinctness and tendinosis in adults. So we'll be looking at that to rejoin that common insertion. And in this case, it's actually slightly tendinopathic. And then the brevis makes it to the base of the fifth, and the longus, we're going to examine that as it goes through the anterior tarsal tunnel through this region here, which is called the cuboid tunnel, and then back up to its insertion. I'm noticing that there is some kind of edema along the lateral calcaneal sidewall, and I'll come back to that on the bony structures, but that's in this region here. So while we're here, let's take a look at the lateral collateral ligament complex and examine. So now we're going to go over to the region of the syndesmosis, all clear on those. There's no inflammation. There's no widening. The interosseous ligament intact. We can see that also on T1 weighted images, that there's no synovitis in those regions. Looking at the anterior talofibular ligament, this is mildly thickened. There is no acute synovitis identified. Looking at the posterior talofibular ligament, we're noticing some amount of mild synovitis. Let's take a look on T1 to get a sense. It's not, it's slightly obliterating the fat, but certainly I can still see the branches and fibers of my PTFL, but slightly indistinct, closer to the complex of the posterior talus. Still something that I would call mild sprain. And then the calcaneofibular ligament seen deep to the peroneal tendons here. That's actually where it's pointing to. And what I'm seeing on the peroneal tendons, the hammock-like band, this is the calcaneofibular ligament here, this structure here that sort of loops around and forms a hammock underneath the peroneal tendons. So that's slightly thickened there. We can see that on T1 weighted images there. So we have this mild sprain of the ATFL and calcaneofibular ligament. It appears chronic, and perhaps a subacute sprain of the PTFL. Then we can move over to the medial ligaments. Let's get a sense of the deltoid. And when I'm looking at the deep deltoid on T1 weighted images, I'm noticing that I cannot find the bands as discreetly as I like to. Like this is a little bit better, but this is kind of inhomogeneous and poorly defined. And that is a location where we're having some mild sprain of the deep band of the deltoid. So that's the deep deltoid, and it's mildly sprained and thickened. And I would give that subacute to chronic. I don't see much synovitis. So just the trace edema or trace signal makes me think subacute to chronic or subacute on chronic. And then moving on to the superficial deltoid, I want to go to the medial malleolus, and I want to see the origin of, mostly I'm looking at the tibiospring many times. Of course, we're noticing, we know that the tibionavicular is on this range, but that's not often torn in my experience. The tibiocalcaneal also back here, that looks pretty good. Looking at the tibiospring, minimally thickened to normal. And now let's get into the region of the supromedial spring ligament, which I'm having a hard time seeing one entire band here. So I'll take a look on my coronal images now to see where is that spring ligament band. And in fact, if this is my tibiospring, this is the region of my spring ligament band, and it's also not well defined on my coronal images. So let's take a look over here and see that there is some kind of synovitis, and there's no fat planes that I can see through this region. And this is consistent with a supromedial spring ligament thickening in this region here. That would be a subacute on chronic sprain for me. Looking at the inferior medial lateral oblique bands of the spring ligament, mostly I look under the talar head and make sure that I don't have any localized synovitis. I think I'm not very reliable in this particular region until we get to the upper order of complete tears. So now moving on to my sinus tarsi and my extensor region. I'm going to take a look inside my sinus tarsi, and I notice that I have obliteration of the fat at the dorsal aspect of the sinus tarsi laterally. I also have some minimal edema at the lateral talar process, which I can see here. And that's a finding that can be implicated in lateral hindfoot impingement. Moving on into that sinus tarsi, more anteriorly, I see I do have my talocalcaneal ligaments anteriorly, but dorsally, they're quite thickened and narrowed there, and with some fibrosis and synovitis occurring. So this is alerting me. A lot of times I see this in patients who have pes planus, and we'll come back to that. Moving on to what I call the ropes of the ankle, let's take a look at the Achilles and the plantar fascia. I'm always looking at the plantar fascia. I like to get a sense of that also on T1 weighted images, whether or not I have any nodularity that I can pick up. Usually on T1 that can help me see plantar fibromatosis, which may be more of a developmental condition in certain types of collagen. But nonetheless, I don't see any of that here. I'm looking at the plantar fascia itself, and I want to understand very carefully, look at that central cord. We're seeing very early changes, even some skin subcutaneous change on T1 right at the central cord, telling me that this is where the patient has pressure points when they heel strike. So that's what that helps me with. I wouldn't go on to call it plantar fasciitis. I think it's telling us a biomechanical clue to how this person strikes the heel. Let's take a look at the Achilles. This Achilles is diffusely the same thickness pretty much throughout, except some mild increased signal at the insertion. Indeed, that's inside the insertion with some trace retrocalcaneal bursitis and a small Haglund bump in this patient who has a small Haglund bump, retrocalcaneal bursitis, and minimal Achilles tendonitis. Remember, the patient's only 14 years old, so I don't expect them to have what would look like, a chronic long-term tear in these regions unless they were an athlete. But these are early findings that can be abnormal in the pediatric population. So we want to have a clinical correlation as well to these findings. Moving on from that region, let's take a look now at the bony structures. The first thing I want to try and clear is my talar dome. And when I look at this talar dome, I can't say that there's any actual unstable bony injury, but there are some features that are atypical, including hyperintense signal change and leading me to these poorly defined sort of chondral areas of partial thickness defect. And I think that you need a higher Tesla magnet to really be accurate about those. But that, again, would just give me biomechanical clues. The real meat in this case is the bone marrow edema that's occurring throughout the medial talar process, which has an abnormal slope from proximal to distal, lateral to medial. And it has an interdigitation with hypointense T1 changes. You can see here nicely on the axial image in a patient who has this fibrous coalition. The fibrous coalition is likely symptomatic. There's bone marrow edema across the subchondral plate. And there's also evidence that there's bone marrow edema along the lateral calcaneal sidewall. So let's take a look up at the biomechanics of this case and take a look at the talar head and how that talar head is slightly uncovered or medially rotated with respect to the navicula. Now, we can't completely see the hallux here, but we can see the base here. And notice that the vector of the talus far medial to that. So we can suspect that this patient has overpronation biomechanics. And one of the things we noticed was that the lateral talar process has edema, and that can be seen in hindfoot lateral impingement. So lateral impingement when the lateral process of the talus tunnels into the angle of Gisane is something that can be seen with overloading hyperpronation biomechanics. And that's what would typically occur if we do have a coalition in this location medially, inferiorly. Think about this area not undergoing the normal biomechanical stresses when we heel strike. There not being the ability to glide at all through this region of the joint. And of course, we'll have to have a heavier pronation strike underneath the talus. And when you think about those things all together, that can help you understand the origin of the ligamentous injuries and help you decide whether or not you're comfortable calling this a spring ligament sprain with synovitis when you see changes that occur here, and help you make a more accurate read. Thank you for your time and attention. I hope that this has been useful.